Hi everyone, welcome back to UWorld's NCLEX Review. My name is Samantha, I am a nurse here at UWorld, and today we're going to be covering COPD or chronic obstructive pulmonary disease. So today for COPD, you can expect to learn about all things about gas exchange, risk factors, clinical features, interventions, and of course our client teaching. We do have a few questions sprinkled throughout to check your knowledge, as well as NCLEX style questions at the end, so make sure you stay tuned for those. Follow us at UWorld Nursing for more information on our live sessions. This will live on demand after we're done, so if you have to duck out early, maybe you can only jump in and out, you're always able to revisit it on our social media channels. I personally find the YouTube channel as the easiest one to search because we have that search bar functionality. As always, drop your comments and questions into the chat. We have the wonderful nurse Jasmine moderating for us today. We always want to hear from you guys, so keep letting us know. Before we get started, I'm going to take a quick detour into our retaker offer. So do we have any NCLEX retakers in the chat today? Maybe the first time you took it didn't go so well and you do have to retake it. We understand the costs associated with retaking, and we do want to help, especially during the holiday season. So we are offering a special offer on NCLEX Review for retakers only. All you need to do is upload that CPR or candidate performance report from your last attempt, and we will send you a link with the offer. See the chat for the link, but definitely a great offer to take advantage of for all of you guys that maybe have to take one more attempt at that fateful NCLEX. Alrighty, so back to COPD. So let's talk about the anatomy and physiology of our lungs first, because it really primes our COPD discussion well. So first things first, we'll start with the basics. We have two lungs, a left and a right. Now our left lung has two lobes, and it's a little smaller overall than our right lung because it has a notch where our heart has to fit. Now our right lung has three lobes and is generally larger than that left lung. So speaking about airflow, when we breathe in our nose, which is going to help to warm and humidify that air, it then travels through our nose to the pharynx, larynx, and down the trachea, which is our windpipe. After the trachea, we have our bronchus, which break apart going both left and right, and then our bronchi, which is just the plural of bronchus, split a number of times, and they get smaller and smaller each time. Now think of this like an upside down tree, where the trunk is the trachea or that windpipe, and the branches are the bronchi, and they're getting smaller and smaller until we have the leaves or the berries or the apples or whatever you want to say is growing on the end of those branches. I want you guys to picture that bunch of berries or apples or whatever you thought at the end of the tree. Picture those branches. So from the trachea, our bronchi or branches split off and break off several times until we get to the bronchioles, which are our berries, so to speak. These are going to be attached to what we call alveolar sacs. So these are really important to our COPD discussion. Alveoli are key because this is where gas exchange happens in our lungs, and therein it's where the problems lie for these clients with COPD. So our respiratory system and our circulatory system work really closely together. Those alveoli have super thin surfaces and direct access to our capillaries consequently. So our capillaries are what's responsible for picking up the oxygen molecules that we breathe in and transporting them through our bloodstream, dropping off carbon dioxide or our waste gas that the body will then exhale. So we breathe in, our blood picks up oxygen, which we like. It then delivers carbon dioxide on the back end, which we don't like, and we exhale that carbon dioxide. This is, in a nutshell, how we breathe. So now that we understand that, how does it tie into our respiratory drive or what stimulates us to breathe? So our nervous system regulates our respirations. It does this by using pH, which stands for potential of hydrogen, or the pH scale. This is essentially a measure of hydrogen ions in the blood. The more hydrogen ions we have in the blood, the more acidic the blood will be. So on the pH scale, our goal is to be right in the middle between 7.35 and 7.45. That is our normal range. Acidic levels will be lower than 7.35, and more alkaline levels are going to be higher than 7.45. We did a whole live based on acid-base imbalances last week, so if you have more questions on that, it is a tricky subject. Please revisit that live on our YouTube channel. normal. But moving back to respiratory, increased levels of carbon dioxide or CO2 will increase our hydrogen ion concentration, making our blood more acidic. So in a healthy client without any of these respiratory problems, a buildup of carbon dioxide, maybe from a period of heavy exertion like some really intense exercise, will alert the brain that, ooh, we need to bring in some reinforcements to help get rid of this excess CO2. This can look like stimulating our muscular system to activate accessory muscles to help us breathe harder and faster and move our diaphragm more to get more air out of the lungs and expel more CO2. This is called a hypercapnic respiratory drive, meaning too much CO2. So when that CO2 rises, alarm bells go off and other systems will be engaged to go ahead and maintain homeostasis. So knowing that, this is really important when we talk about COPD in our clients with COPD. So we'll move to our types of COPD image, but COPD or chronic obstructive pulmonary disease is a progressive, irreversible lower respiratory tract condition. So progressive and irreversible meaning we can't undo the damage once it's already been done, and it affects our lower respiratory tract. So we're going to think of problems at the end of that tree, or the metaphor we spoke about earlier, or problems with our alveoli and gas exchange. So again, COPD is an umbrella term for obstructive lung diseases like emphysema and chronic bronchitis. So COPD has two defining characteristics that I want to make sure you guys take away from this. So the first characteristic is airway obstruction. Clients with COPD, no shocker, have an inflamed airway, meaning that the airway all the way down into our branches or bronchioles, and they'll also have increased sputum production. So in this case, it's going to obstruct air from filling the alveoli as well as air from escaping that alveoli. The second thing that we're going to see with COPD is air trapping. So in a normal healthy client without COPD, those alveoli that we talked about, or the berries, so to speak, are super elastic. They're like grapes, they're stress balls, they're compliant, they're flexible. When we inhale, they expand, and when we exhale, they deflate and squeeze that air out as we exhale. However, in our clients with COPD, those alveoli lose their elasticity. They're no longer flexible. They're more like a droopy, less compliant raisin. This is going to cause air trapping. So air just sits in those alveoli. It can't get out. We have trapped carbon dioxide or CO2 in those alveoli. So let's put this together to paint a clinical picture. So because our alveoli are weak, non-flexible, non-compliant, and our infrastructure of that respiratory tract is inflamed and full of mucus, it's therefore harder for oxygen to get delivered as well as for carbon dioxide or CO2 to get expelled. We just talked about that hypercapnic respiratory drive in a normal healthy client. In COPD, remember we said progressive and irreversible damage. So over time, the body adjusts to chronically elevated levels of carbon dioxide, and it no longer becomes a trigger for our breathing or for our ultimate respiratory drive. So instead of having a hypercapnic respiratory drive like a healthy client, clients with COPD, especially advanced stage COPD, will have a hypoxic respiratory drive. So they respond to decreased levels of oxygen in the blood. That's going to drive the respiratory centers in a client with COPD. So again, COPD clients become accustomed to slowly climbing levels of CO2. It becomes their norm, and it's no longer a driver for the breathing centers of the brain. So healthy client has a hypercapnic respiratory drive. The body responds to high levels of CO2. In a COPD client, the body only responds to hypoxic conditions, so hypoxic respiratory drive or low levels of oxygen. So not only are we going to see these structural changes to our bronchioles and alveoli, we're also going to have changes to the actual lung tissue. And the biggest one here is our lungs become hyperinflated. They're enlarged from all of that trapped air. This increases the size of our lungs, and it's going to in turn push down on our diaphragm and flatten it out. So the diaphragm is really important to help support our respiratory drive. When we push down on that and flatten it out, we lose a lot of its function. So that's a really important structural change to make sure you understand. So that was a lot. That was a lot of chemistry, but I hope that was helpful. Take a minute for a deep breath, no pun intended, and we're going to do a quick question about gas exchange. So true, false, let me know. Hypercapnia means high levels of oxygen in the blood. True or false? I'll give you a second. Hypercapnia, does that mean high levels of oxygen in the blood? Let me know what you think, true or false. Who thinks that's correct? Who thinks that's incorrect? Let me know. I'll give you a few more seconds. Awesome. I see a couple falses coming through. You guys are spot on per usual. So false. Hypercapnia means high levels of CO2 in the blood. High levels of oxygen is not anything we've even talked about today. So hypercapnia equals high CO2. All right, so moving along to our COPD table, let's talk about some risk factors. These are going to be pretty obvious. Just think about irritants to the lungs. Obviously, first and foremost, smoking, tobacco consumption, all of those things we know is a risk factor for just about anything you come across in medicine, as are prolonged exposures to respiratory irritants. So things like living in an environment with a lot of air pollution, maybe working a job with a lot of chemical fumes, being around a lot of smoke, maybe living in an arid climate where there's a lot of dust, like out in West Texas, for instance. There's also a genetic component to COPD. So it's something called an AAT deficiency, which stands for alpha-1 antitrypsin. Essentially what AAT does is it protects the lungs from damage that's caused by inflammation. So when we have a lack of this, it then in turn increases our risk for developing COPD down the line. Any history of recurrent respiratory illness in childhood also puts a client at a higher risk for COPD. This can be something like asthma, which is very common, recurrent pneumonia, bronchitis, really any scarring of the lung tissue increases the risk for development of COPD over time. So these were all pretty intuitive, nothing crazy here. But let's flip the script and move on to clinical features. These are going to focus on hypoxia over time and the respiratory complications that stem from it. So again, we talked about our two main features of COPD being air trapping and airway obstruction. What does this cause in a clinical setting? So let's start with dyspnea, or difficulty breathing, right off the bat. That makes a lot of sense when we think about those two main clinical features. Dyspnea will start off as occurring at times of exertion. Maybe the client is exercising, maybe they're on a walk, and then it progresses to happening even at rest. So clients may also have wheezing due to the swelling of the airway and that mucus production. Air isn't able to flow freely like it should. Clients can also develop a chronic cough from that increased sputum. We can also see something that's colloquially termed barrel chest. So I always remember this being associated with COPD, but I never really understood why. So I'll tell you, bringing it back to our air trapping in the alveoli and the hyperinflation of those lungs. As the lungs grow in size over time, our muscles and our cartilage are going to remodel themselves to give the lungs more room to grow and expand. This is what results in that big barrel chest. And there's a similar patho here with clubbed fingernails that we see in COPD. Essentially, capillaries in our fingers as well as our toes are really, really small. And as we become hypoxic, we don't get enough oxygen. It causes them to remodel and to grow new blood vessels, which causes them to get larger and develop that bulbous appearance on the nail bed. Lastly, we'll also see fatigue from this hypoxia. So since we have decreased circulating oxygen in the bloodstream, anything that requires an exertion of energy, maybe a little burst of exercise, is really going to fatigue these clients since they have low levels of oxygen. So to sum all those clinical features up, quick recap, think dyspnea, cough, barrel chest, clubbed nails, and general fatigue. Alrighty, so up next is our diagnosis section. We have a couple of different ways that we can diagnose COPD. They all kind of work hand in hand, but spirometry can be used to measure the amount of inhaled and exhaled air during the respiratory cycle. A client with COPD will produce low levels of expiratory pressure. Remember, they can't get that air that's trapped in the alveoli out, so they'll have low levels of expiratory pressure. A chest x-ray may also show blebs, which is just the air trapping in that alveoli, shown up on an image. And lastly, we can also monitor our ABGs to bring those back into play, those arterial blood gases. So clients with COPD will see increased PaCO2, or increased blood carbon dioxide, and decreased oxygen. This means they're in a state of respiratory acidosis. Again, that ABG session will really help to explain more of the features of ABGs and acid-base imbalances. If anyone is interested, it's on our YouTube channel. So jumping now to a COPD image with that hyperinflated lung. COPD has some pretty big complications. So let's just jump into some of these scary features. First, it can lead to pulmonary hypertension. So bringing it back to basics, we know we have air trapping, we know we have airway obstruction and inflammation. Our vessels are going to remodel themselves, and this in turn increases the pressure in our pulmonary arteries. So when we have hypertension, it's similar as like having the blood run against the wind. It's the same principle with the blood going to our lungs. Over time, this pulmonary hypertension is going to lead to things like right-sided heart failure or cor pulmonale, causing fluid to accumulate throughout the body. Alrighty, and now we're going to go ahead, and if anyone knows any of the findings associated with right-sided heart failure, go ahead and drop them in the chat. Let's see what you all are thinking. I'll kind of go through them concurrently, but right-sided heart failure that we know this can lead to can look like jugular venous distension, or JVD. We can see ascites, or the inflammation collected, the swelling and fluid in the belly region. We can also have general edema. These clients have an increased risk for developing pneumonia from this, and can even push them all the way into respiratory failure. So a lot of really serious complications here. So now let's compare a COPD client to a healthy client. We're going to pull up a COPD client's lung versus a healthy lung image. So long-term management, again, COPD is progressive. It's a long-term condition. So we have to be thinking about big picture because the damage is irreversible. We're going to pull up this image of a COPD client compared to this healthy client, so you can see just how much damage has been done in COPD. So starting off, let's focus on our modifiable risk factors, the things that we are able to change. First and foremost, you guys can probably guess this, smoking cessation. We always counsel our clients to quit smoking, doesn't matter what area of medicine you are working in. We also want to encourage pulmonary function, so maybe a pulmonary rehab referral. We want to reduce the risk of acute COPD exacerbations that can stem from things like infection. So educating the client about the benefits of vaccines like the flu vaccine, the yearly flu shot, the pneumonia vaccine, all really important, especially in our older populations. There are medications that can be used for the chronic management of COPD, and these include our long-acting bronchodilators. So they're given to open up that airway, salmeterol, which is a beta-adrenergic medication, or tiotropium, which is also an anticholinergic medication. Clients can have inhaled corticosteroids to help reduce swelling in the lungs, and we can also give expectorants to thin out that mucus. This allows clients to be able to cough up and expectorate that mucus because it's being made thinner. A common example of this would be Mucinex, which is the trade name for guaifenesin. Another little note on that, those only work if we drink lots of water to hydrate and help thin that mucus out. It's always easier to cough up and expectorate thin mucus than it is that really sticky, thick mucus. Alrighty, and now for the biggest kicker of COPD, and that is supplemental oxygen. Kind of a tricky subject here. This is where that whole big long story that we talked about at the beginning with gas exchange really comes into play. So we said clients with COPD respond to a hypoxic respiratory drive instead of a hypercapnic respiratory drive in a healthy client. So when we give these COPD clients that supplemental oxygen, we want to make sure we're only giving it to maintain an O2 sat between like 88 and 92. Usually the magic number is right around 90, and let me tell you why. If we try and get our COPD clients to have O2 sats greater than 95%, that's typical in a healthy client, we can actually cause them to hypoventilate or breathe too slowly or too shallowly. So again, a client with COPD is blunted from responding to that hypercapnic respiratory drive or those increasing levels of CO2 because their body has become so accustomed to rising CO2 levels in the body. The body's like, no big deal, I'm not worried about this. Instead, in a COPD client, it listens to oxygen levels in the blood. So if we give supplemental oxygen and we turn it up really high and we force a bunch of oxygen into the client, how that hypoxic respiratory drive works is it's going to see all that oxygen and be like, oh, great, our lungs crushing it. No need to breathe as hard as we have been, and it will actually in turn suppress the client's respiratory drive. That is the danger there. So as we've always said, the NCLEX is an exam about safety, so this would be a good takeaway to remember from today's session. We never want to over-oxygenate our clients with COPD because it is not safe. It can blunt the body's respiratory response. Instead, we want to elect to deliver our client titrated that oxygen to the lowest amount needed to maintain O2 sats around like 90%. That's really an important takeaway here. So lastly, let's look into management and teaching. Let's talk about acute management for our COPD exacerbation. So again, COPD, chronic obstructive pulmonary disease, but we can be in an acute phase during an exacerbation. So starting out with medications, we can expect to give medications like a nebulized bronchodilator to really quickly open up the airways and the lungs, also help to dry up those secretions. Examples of this would be an albuterol, which is a beta adrenergic, or an ipratropium, which is an anticholinergic. We can give oral or IV steroids to help reduce swelling and ultimate inflammation we can see in those airways. And we can also give antibiotics because a lot of times these acute exacerbations of COPD are caused by an infection. That's like the problem at the beginning. So giving antibiotics helps to stamp out that root cause. Clients may even need respiratory support like a BiPAP, and in extreme cases, extreme exacerbations, they may need to be intubated. So our last topic is teaching. We have to teach these clients about how they can get maximum respiratory function out of their lungs. So we can be expecting to teach things like airway clearance techniques. Percussion and vibration on the client's backs can help to move around, loosen up those secretions, making them easier to expectorate. We can also use postural drainage. It can be used if fluid buildup occurs on a certain side of the lungs, so we can teach the client to reposition themselves to help, again, get that fluid moving, make it easier to expectorate. Huff coughing is a great technique here. It can be taught to help clear the airway by engaging those abdominal muscles. So instruct the client to inhale through the nose and relax the abdominal muscles, then lean forward and exhale sharply with 2 to 3 huffing sounds that contract the abdominal muscles. This helps give it that little extra push to expectorate some stubborn sputum. We can teach the tripod position by making a tripod, so a triangle with the arms, the core, and the lap. We create larger surface area for our lungs to work, which in turn offloads the pressure, making breathing a little bit easier. Pursed lip breathing, big one I'm sure you've all heard about too. Another technique we should teach these COPD clients. We teach them to breathe in through their nose and then breathe out through their mouth in a long, slow manner through the pursed lips. What this does is increase the positive pressure in the airways, which helps to expel some of that trapped air that we see in our alveoli. A cool mist humidifier may also be really, really restorative at home. Humidified air, again, when we take an expectorant medication, we have to be really hydrated, have to be drinking lots of water. It's the same thing with having humidity and water in the air. It can help to hydrate and thin out those secretions, making them easier to cough up. We want to encourage these clients to maintain hydration at least 2 liters per day. And nutrition. A lot of times these clients, we really don't want them to get full or overly full. So, Christmas dinner, Thanksgiving dinner, we have to be taking it easy. This is because the increased pressure from a really full stomach puts pressure on the diaphragm, which in turn puts pressure on the lungs, making it more difficult for these clients to breathe when it's already hard enough for them to breathe as is. We also want our clients to drink fluids between meals instead of with meals to prevent that stomach from overfilling, keep that volume down. And we want to encourage small and frequent meals that are really high in calories. Again, these clients, if you're struggling to breathe, your metabolic demand is huge. You are burning so many calories. They're not always going to be able to stomach large meals. We don't want to overfill that stomach. So we're going to give frequent meals that are really calorically high, protein dense. And we want to avoid gas-producing foods like a cruciferous veggie. That's the cauliflower. That's a broccoli. Good news for all of you veggie haters. We want to avoid those to make sure we're not filling that stomach with air or that cruciferous veggies will produce gas, and we don't want to overfill that stomach. So let's wrap things up today. You guys did great. We're going to go ahead and jump to our NCLEX style questions to test our knowledge today. Alrighty. So question 1. Here the nurse is talking with a client with COPD who is reporting recent weight loss. The client states that bloating, exhaustion, and dyspnea make eating difficult. Which of the following responses would be appropriate for the nurse to make? And it is a select all that apply question. So our options are: use your bronchodilator before meals to decrease the work of breathing while eating. Drink fluids between meals instead of immediately prior to or during meals. Increase your intake of high fiber foods like broccoli and cabbage. Take a short walk before each meal to help stimulate your appetite. Or lastly, eat small, frequent meals that are high in calories and protein. The good news is we just went over this, so hopefully it's still pretty fresh in y'all's brains. In the meantime, let us know, what are your Christmas plans? What are your holiday plans? Who is staying put at home? Who is traveling? Any destination Christmases? We are always excited to hear about that. I know a lot of you too are probably winding down your school semester, so best of luck on your final exams. This week is probably the final push, so you're so close, you can do it. All right, I'll give you a few more seconds to go ahead and drop those answers in the chat. Again, COPD is a complex topic, and you guys have done fabulously today. Way to go. All right, and I see a lot of combinations of the right answers, but I don't think I see one that's fully, oh, there we go. All right, so 1, 2, and 5 were our correct options here. It looks like we may have been a little bit confused on this one. So why was this true? 1, use your bronchodilator before meals to decrease the work of breathing while eating. We want to make sure we maintain nutrition in these clients. That bronchodilator will help to open up the airways, which will help breathing easier, which in turn makes eating easier. If you have ever struggled to breathe or felt like you couldn't catch your breath, the last thing you want to do is put something else in your mouth and chew and make it even harder to breathe. So if you can't breathe, you're not going to want to eat. So we have to make sure we use that bronchodilator to open the airways, make breathing easier, so these clients can even consider wanting to chew something. Drink fluids between meals instead of immediately prior or during meals. Remember, we have to avoid that stomach volume getting too full, which puts pressure on the lungs and the diaphragm and ultimately makes it harder to breathe. When a client eats, also adding fluid can be a little bit too much, so we try and stagger. We want them to be drinking lots of water, but we want them to do it in between meals, stagger it as opposed to during meals or immediately before. Our last correct option was that small, frequent meals. So true. When we have increased work of breathing, our metabolic demand skyrockets. We are burning so many calories when the body is fighting to get breaths in. So in this case, we have to make sure we're meeting that metabolic demand with some really nutrient-dense, high-calorie, high-protein meals. 1, 2, and 5 are all correct options. 3 and 4 were incorrect. Why was this? So options number 3, high fiber foods produce gas, which in turn increase that stomach volume, which again, we're trying to avoid because it can put more pressure on the diaphragm and the lungs. Broccoli and cabbage are those cruciferous veggies that we want to avoid. And also 4, take a short walk. This will not stimulate your appetite. When we increase that oxygen demand, when we do any kind of exercise, this will make breathing more difficult. And again, if you're struggling to breathe, you are not going to want to eat. This will not stimulate the appetite. It will do the opposite. So again, 1, 2, and 5 were our correct options. Way to go, you guys. Alrighty, question 2. The nurse is observing a staff member caring for a client with COPD. The nurse should intervene if the staff member is observed, demonstrating pursed-lip breathing to the client, providing the client with information about smoking cessation, administering albuterol to the client before meals, or hyperoxygenating the client before assisting the client to ambulate. Drop those answers in the chat. Let us know what you all are thinking. This is an intervene question, meaning we are looking for an incorrect action. Always important to make sure we're reading the fine print of these NCLEX questions. And in the meantime, I see a couple of you guys are just going to be staying home for Christmas. That is the best kind of Christmas. Also, let us know what topics you all want to see us present on. I know a lot of exams are coming up. Is there one topic that you want some more help on? Maybe you struggle with OB or PEDS. Let us know so we can make sure to hit that topic extra hard before we head out for the holidays. Alrighty, lots of answers coming in, and I see almost all option number 4, which was the correct option. Way to go, you guys. So again, intervene means we're looking for an incorrect action. And in this case, hyperoxygenating the client is going to be an incorrect action. Remember, instead of having a hypercapnic respiratory drive like a healthy client, clients with advanced COPD have that hypoxic respiratory drive. Over-oxygenating them is going to blunt their respiratory drive, which is going to make them hypoventilate and really not breathe enough. So in this case, this requires intervention. Therefore, it's our correct option. All of the other things are correct interventions, so we don't need to intervene. We want to purse-lip breathe for these clients. It helps to increase that expiratory pressure. We want to provide a client with information about smoking cessation. I don't think I've ever seen an option on an NCLEX question that says to encourage a client to quit smoking. Be wrong. So if you ever see that, that is just what you want to do. And also administering that albuterol to the client before meals is going to open up their airway, make breathing easier, which in turn is going to make eating easier. So in this case, option 4 was our correct option because it requires intervention. But great job, you guys. Almost all of y'all got that one correct. Before we head out, let's take a quick look at our QBank slide. So for all of our UWorld users that already have the product, here's exactly how to filter on the question bank or QBank to get more questions about exactly what we talked about today, so you can continue your practice today. It's always a great idea to practice what you learned while it's still pretty fresh in your head. And for anyone that has not purchased UWorld yet, here's a sneak peek into our QBank and just one of the many, many ways you can filter our questions to focus in on exactly what you want to work on. Thank you so much for joining today. We'll be back Wednesday, Thursday, Friday, and Sunday this week with more live material and question drills. Thank you so much for joining. Make sure you take advantage of that retaker offer if it applies to you, and I will see you all soon.